Okay, this is my presentation. I'll have to do it through video feed because I couldn't get my PowerPoint to work. However, I am uploading my PowerPoint if you'd like to go along with this. Okay, so disablement models provide the framework to ensure comprehensive, patient-centered, whole-person healthcare assessment that allows an easy breakdown for clinicians and researchers to examine the effectiveness of healthcare services. Both clinician-based and patient-based outcome measures are important as defined by the disablement models. In combination, these assessments can provide whole-person health-related quality of life for the patient. The ICF classification model has been used for the scenario I am presenting to assess other dimensions of disablement such as environment and personal factors. However, we need to remember that disablement models are just meant to be utilized as conceptual frameworks, not a tool to utilize in clinical setting. So the scenario that I picked was an 18-year-old female lacrosse player playing collegiate lacrosse at my institution. She was injured in October of 2015 while she was doing team lifting. They were doing jerk exercises when she felt pain in her shoulder. She was evaluated by the athletic trainer and then again by the team physician, and with an MRA was confirmed to have a slap lesion tear. So in January 2016, she underwent shoulder surgery. And so since January until presently, she's in her lacrosse season. However, she's not participating. She hasn't been cleared to run. She's only doing exercises with her athletic trainer and using the upper body bike and the lower body bike for cardio activity. So she really hasn't been doing that much. So I used the disablement model, the ICF model with the codes to try to break down what exactly was going on with this athlete as far as function and structure and activity, participation, environment, and all of those things. And some of the things that I discovered and were really red flagged on that I wouldn't have if I hadn't done the dash and also looked at her through this ICF model. The usual stuff, she wasn't able to put her hair up or put her own clothes on or change herself or wash herself. And that stuff was there for a little bit, but then it went away. So I think she was a little bit depressed and angry because she couldn't take care of herself. But once she was able to move around and able to do things on her own and get a little bit more range of motion, some of that stress had gone away. However, some of the stressors that I did see, especially with activities of daily living and her more conceptual skills like lacrosse, social life, and education, were things that I noted as red flags. So this is also one of my athletic training students who's taking orthopedic evaluation with me. So while we were in class, she was getting really frustrated because when we were doing range of motion, selective muscle tests, range of motion tests, special tests, those types of things, she really wasn't able to participate in that part of class and felt as if she was getting behind. So she was listening to the lectures but not able to participate. So she really was feeling isolated in herself. And the other area where I really felt that I saw some red flags and weakness were in lacrosse. Normally, when someone has surgery, they're not participating. So it's our job to make sure that they feel like there's part of the team as possible. And one thing that I found after looking at the model and talking to her was that during practices, she was doing the timer. So she was up in the press box and wasn't with the team. And then during the games, she was also across the field filming the game. So at no point during practice or games is she with her teammates. And so I really think that that has hindered her in her ability to be motivated and to get out of this depressed state. And so she really, for a while now, for about 2 months, she's alienated herself from her friends, from her teammates, and from her classmates. And she's very sleepy. She doesn't pay attention. She's moody. She's quiet, and she's kept to herself. And those are just some things that I've noted. But when you talk to her and you go through this coding, it's really obvious how many problems are really going on beyond being on the field for lacrosse. The other problem I noted is that her parents are about 200 miles away, so most of her social support is not here. And so I've seen um, a big difference in her attitude towards her athletic trainers, her attitude towards me in class, her attitude towards her coaches, and even her friends. And so those are some things that become barriers, and if we can't get them to change, she's not going to improve her function and her ability to socialize and physically and mentally be healthy. I chose the dash to use as my optimal instrument of choice because of the long history of research with post-surgical patients and because it incorporated the athletic module. The dash is a regional outcome measure that was initially developed by the American Academy of Orthopedic Surgeons Outcome Research Committee and the Institute of Work and Health, and it was an attempt to develop an outcome measure that reflected the effects of upper extremity diseases and injuries on upper extremity function. The dash was first published in 1996 and has also developed two short versions, the Quick Dash and the Quick Dash 9. This form has been translated in 41 versions. The DASH questionnaire includes 30 items that assess physical function in patients with diverse upper extremity musculoskeletal conditions, and it is rated on a 5-point Likert scale. It contains questions relevant to function, symptoms, limitations of social functions, as well as additional optional modules addressing work, sport, and/or music function, intended for patients with a variety of arm, shoulder, and hand conditions. The domains of assessment for the DASH are appropriate for the general population. However, through my research, I discovered that the DASH is not sensitive to high physically function athletic individuals. So on the DASH, scores range from 0 to 100, like I said before, with higher scores indicating higher levels of disability. Clinicians do not require any training to perform the questionnaire, and it is free of charge on the website. The MCD and MCID dash scores generally are between 10 to 12 points for most studies out of 100. However, a little bit later in the discussion, I'll talk about some of the differences that they found with among the MCID and MCD scores depending on the variables that you have in your study or your patient population. But as long as a patient sees from test to retest, a 10 to 12 difference in their numbers out of 100 that's decreasing, that means there's been meaningful change for that patient, whether it's intervention, treatment, rehabilitation, whatever. In my scenario with my patient, I took her DASH score in March, and she was at a 27 out of 100. And then we took it again 2 weeks later, and she was 12 out of 100. So even with her, once we got through the hard part after the surgery where she couldn't really move around and do stuff for herself, once she was through that part, she was still struggling with some of those red flags that we talked about earlier, but you could see that there was starting to be meaningful change in her treatment. And after we had gone through and talked to her coach and talked to her athletic trainer and made some changes in some of the things that she was doing out at practice and ways that I could get her involved in the classroom, we started to see some improvements in her ability to function better and have less disability or dysfunction. So the DASH is an acceptable questionnaire for adults 18 to 64 years of age. It can be accomplished within 5 to 30 minutes. It can be used in younger populations. However, the DASH does have one question that may be inappropriate for the younger population, and it deals with difficulty with sexual activity. But the cool thing with the DASH is that you're able to either on purpose or from error omit at least 3 questions off of it and still get accurate scores. So even if a clinician chooses to omit that question, you can still calculate the scores electronically or by hand. The instrument appears to assess all levels of the ICF disablement model. However, like most PROs at this time, there are still weaknesses assessing the physically active person. The really neat thing that I found about this dash was that it is in 50 different languages. And for my institution, we have a high number of international athletes. So I think that would be really successful there because we would be able to give um, an outcome assessment that doesn't have that language barrier. So we could provide an assessment to different languages so that people were more likely to respond to the assessment and to not omit questions because they don't understand what's going on. So I thought that that was pretty neat. The score is interpreted for clinicians is minimal, really under 5 minutes. And if you choose to use the electronic version, it calculates in seconds as soon as the person is done completing it. So I think the interpretability is pretty good. It's easy to use and it's friendly and likable. And so I think this is a good one to use.